Thank you for taking the time to join us for this short webinar on PDPM, in-house versus contract therapy. We're going to discuss the financial and clinical considerations applicable to both models. I'm Lee Lashney, VP of Business Development for TMC, and we would love your comments and questions. If you'll please put them in the question section and we'll go over those at the end of the presentation. I want you to know on the front end that this is not a pitch for either model. I simply want to share with you what we've learned over the past months at C-suite conferences and by completing audits of both types of programs. There's been a lot of dialogue over the past year due to PDPM. Providers have been asking themselves, what is going to be the financial impact of PDPM? What do I need to do to prepare? How would the delivery of therapy services change when minutes no longer matter? These questions have also led providers to looking at their therapy options. Should I go with the in-house model or with contract therapy? What things do I need to take into consideration? First of all, whenever we make major decisions, it's always good to look at the pros and cons. From an in-house therapy standpoint, the pros are that you do have control over operational and clinical decisions, as well as the selection and oversight of your team, and that leads to team cohesiveness and continuity of care. Of course, you don't share reimbursement in this model. The cons are that you may take on additional legal and financial risk, and PDPM is a big clinical paradigm shift for therapists. How are you handling that? You also take on the payroll and benefits cost, as well as the expense of recruiting and onboarding. There may be additional costs related to denials, software licensing, and also staff development. Now let's look at contract therapy. The pros are that it is risk sharing, and the therapy providers typically do a good job of managing the delivery of care model under PDPM. They take on the salaries and benefits, so that could be a savings to you, as well as they take on the responsibility of recruiting and staffing. Included in their services are denial management, census development, marketing and branding, and therapy software. The cons under this model are that you do have less control over operational and clinical decisions. You have less control over the selection of your team, which may impact team cohesiveness, and there is a potential of working in silos. And of course, with this model, you do share revenue. There are a lot of things to consider when you're trying to decide, but I've narrowed it down to key items related to financial and clinical considerations. These are the areas that have been discussed at many of the conferences we've attended over the past year. First of all, from a financial standpoint, we'll talk a little bit about labor and benefits cost, legal risk, denials, and efficiency. From a clinical standpoint, we'll look at the implementation and oversight of clinical programs, outcomes, and your clinical niche as it relates to census development. The average salaries of therapists are between $58,000 and $105,000. This averages to about $37.20 an hour. This will vary in different parts of the country, and we do expect a downward trend due to PDPM. You will also look at an additional cost of between 18 and 22% in benefits. The average recruiting cost per full-time employee is around $5,000. It costs an additional $2,500 for training and orientation. So the average to recruit and onboard one full-time employee is around $7,500. The other thing that you need to pay close attention to under the in-house model is PRN or contractor coverage for illnesses, maternity leaves, or vacations. And last but not least, staff development. Are you going to incur the cost of the CEUs needed to renew therapist license? How are you going to keep them up to date on the most innovative treatment strategies as well as any regulatory updates? I'm not going to go into great depth on the legal risk, but we know that liability and compliance fall into that category. From a legal standpoint, you will need additional liability insurance, and also you would take on the cost of potential lawsuits related to therapy. Compliance includes, but is not limited to, coding procedures and billing codes. How will you keep up with any changes? The same with appropriate documentation. Who will be responsible for auditing the documentation and doing training when you see trends? And last but not least, you have to be aware of any HIPAA violations. This leads us into denials. We know under PDPM that there are going to be new risks for audits. There'll be new parameters that they're looking at for denials, and also there could be possible recoupments under PDPM. Now today we're just going to talk about the average labor cost per claim. The numbers I'm going to talk about do not include the cost of the claim if it's lost. The cost of appeals at the ADR level is around $500 per claim, and again, these are just labor costs. Redetermination is around $400, reconsideration at an additional $600, and if it goes all the way to the ALJ, $1,600. So that would be around $3,100 total if it went all the way to the ALJ level. The last item we're going to talk about under financial considerations is efficiency in delivering care. The efficiency needs to be a minimum of 72%, and most in-house programs are between 55 and 70%. The other thing you have to look at is the delivery of minutes, your historical minutes and your actual minutes under PDPM. There could be potential CMS payback. In the financial seminars that I've attended, everybody agrees that if you're unable to manage the efficiency of your therapy team, you'll lose your shirts and labor costs. Those are their words, not mine. Under PDPM, you want your therapist providing those interventions that have the greatest impact on outcomes and quality measures. Here's an example of a 10-facility chain based on PDPM methodology. The costs you see at the top, their expenses, are just the salaries and wages, benefits, and the administration fees. This does not include any marketing, census development, meeting time, etc., that may be affiliated with the therapy program. So this particular chain, their in-house therapy expense with salary and wages, benefits, and administration was around $486,000 a month, which was annualized at about $5.8 million. The next area is what you have to pay attention to. They really did a decent job on their productivity and efficiency, but under PDPM, you are not going to be able to continue at that level. Remember, we have to have at least 72%, and you can see they were just at 70. So how are you going to manage that? The cost of contract therapy is typically around 19% lower. Now let's look at the clinical considerations and questions that you need to ask yourself based on both types of programs. We want to look at your clinical programs, your outcomes, and your clinical niche as it relates to census development. Under your clinical programs, how are therapy and nursing working collaboratively to improve quality measures? How are you tracking the success of your clinical programs? Clinical programs are all well and good, but if they're not moving the needle on quality measures, what good are they? The next is implementing clinical pathways. Who is going to be accountable for implementing those? Because they both have a nursing and a therapy component. And how are you going to determine the effectiveness of those clinical pathways? Also, the appropriate use and management of individual versus group and concurrent modes. How are you managing that? What is most clinically appropriate when using group and concurrent? We don't just need to use group and concurrent just because we can. They must bring clinical value. Outcomes. These are important when you're trying to show your value proposition in the market. These are your proof sources. First of all, do you know what your outcomes are? It's important to be able to validate the effectiveness of your therapy program. Are you able to track functional improvement, length of stay, hospital readmits, the cost of episodic care, etc.? This is not only important to your primary referral sources, but also to managed care organizations, ACOs, and hospitals participating in bundled payments. From a clinical niche standpoint, we could have really probably put this under financial as well, because we all know census helps drive your finances. But can your therapy program help develop a clinical niche to show your value in your market? How do you identify and address the hospital pain points in your market? With so much competition, it is important that therapy works side by side with nursing to show how you are making a clinical difference with your referral sources. Here's a question to ask yourself. How will you determine the success of your therapy program under PDPM? Last year, we asked a panel of long-term care CEOs, CFOs, administrators, and vice presidents of operations this question. The answers were simple but clear, and they all relate to your financial and clinical success. First and foremost is patient satisfaction. Your patients want to know that they are being well cared of and getting a good return on their investment of being in your facility. Improved outcomes. As I mentioned before, we have to make sure we know what that looks like. Are we tracking those? How can we share those with our families, our referral sources, our patients to show the value? The next one I thought was interesting. They talked about nursing and therapy efficiency. And how do you track that? How do you determine that both are being efficient? It's really important to have evidence-based clinical programs. As I mentioned before, I will always stress this because we have to show how they move the needle on the quality measures. And last but not least, looking at the cost-efficient delivery of care. Both models can provide these results if you have the resources and processes in place to be successful. Success is a journey, not a destination. We are all on this PDPM journey together. Whether you choose an in-house or contract therapy model, your goals are the same: to provide cost-efficient, quality care that improves outcomes. Thank you for your time today.